So thank you very much, Grigory, for a nice introduction. It's always a great pleasure to be in Russia, and particularly in Peter. And I will continue this talk on diagnosis and a little bit intervention in the abdomen on talking about trauma. Our life is full of mistakes, and I have just chosen 6 principal mistakes that you may commit by examining patients with abdominal trauma, and I will also try to tell you how to avoid them. So mistake number 1 is certainly a mistake of organization, and it would be a very big mistake not to place the CT machine in the emergency environment. So if ever you have an influence on conceiving the emergency environment in your hospital, you have to argue that the CT has to be immediately at the emergency room, and it should even be inside the shock room. This is a very important message. The second important message is, if you have to choose equipment for emergency patients, and in particularly trauma patients, you should choose the best equipment you have, and not the old equipment should go to the emergency environment, but the best should go there. Why this? Because the number of human lives lost, expressed in terms of year, by trauma, equals those that are lost by cardiovascular disease and cancer altogether. So trauma is really responsible of a considerable loss, not only for the individual, but also for the society and for a given country. And even better than that, I would recommend to you to install also the angio inside the emergency environment. And a couple of years ago, this is the point, I guess, yes. A couple of years ago, I can point also here, it's even easier. I didn't find it, yes. We developed this prototype, which is an integration of the CT and angiography. And at the beginning, there was a movable table. And now we have a very compact solution where you have a complete angiography together with the CT. And you can switch from the CT to angiography. And you can also switch from angiography to CT. And I will give you examples. This, of course, is a little bit elaborated, sophisticated, I agree, but it is really of great importance in management of the trauma patients. So my recommendation would be that you have a very spacious shock room. Should be 60 square meters. 60 square meters you need. And free access to the patient at any time, whatever the imaging modality is that the patient is just undergoing. And there should be no limitation of movement of the intensive care physician, the trauma surgeon, and the anesthesiologist, of course, to the patient. And the message now is, with the rapid time of examination of CT, both procedures are going together, resuscitation and the CT. And the resuscitation is going on during the CT examination because it takes less than 5 minutes to get the complete investigation of the trauma patient with the CT. So it's not a special examination, another process. It is really integrated. The diagnostic CT of the trauma patient is integrated in the resuscitation of the patient. And there should be, of course, in order to have the machine functioning, dedicated trauma radiologists and angiographer on duty day and night all the time. Mistake number 2 would be a mistake of not organizing your rooms, but of organizing your activity. Trauma is a process which is going on in a standardized way. Trauma kills in a pre-set format, and the mechanism of trauma is always the same. Therefore, you need standardization. In all respect, the anesthesiologist has standardization, the trauma surgeon has standardization, and we as radiologists, we need standardization of our examination protocol. The second mistake would be that there is not a very good cooperation within the team with the other physicians. So deficient or no interdisciplinary team cooperation really has a bad influence on the outcome on the patient. And then concerning us, the radiologists, hesitant or unreliable formulation of the diagnosis also has very negative effect on the patient management. So it's very important to agree with the other physicians to use the same vocabulary. The meaning of the words has to be exactly the same. Extravasation, does it mean that the patient has ongoing bleeding now or do you just see extravasation but the patient is not bleeding anymore, really clinically speaking? Just one of the problems where the vocabulary has to be defined really in agreement with the entire team. So I go on with my recommendation concerning standardization. First, the patient positioning. I feel that the standard positioning, supine, head first in the machine and the arms by side, and finish. And don't discuss anything more. And then in the literature there are other fancy descriptions and so on. Repositioning, for instance, a standard position for head and cervical scanning, then rotating the patient and the arms up. It's crazy, absolutely crazy. Cannot be done really with polytrauma patients. One little nuance. If you elevate the arms, the patient being in a supine position, and you elevate the arms to 30 degrees and you fix the arms in that position, that will get rid of most of the artifacts. And this is a very nice, very simple procedure in order to get less artifacts, despite that the patient stays in a supine position. The next question concerning standardization is oral contrast. Should we give oral contrast, yes or no? Of course, the answer is no. There's no time in a severe polytrauma patient, in a shock patient, to give oral contrast. So this is completely finished. It's a waste of time. It rarely contributes really to the diagnosis of a GI tract in particular, because that was the reason why the oral contrast medium was given, or other abdominal injury. It does not help to identify the injuries that require surgery, and there is a potential risk of vomiting and aspiration. So in some patients, very few, particularly with penetrating trauma, then we can give oral contrast, but usually not at the beginning at admission, but on the delayed, on the repeated CT examination. So forget about the oral contrast, it will not be given anymore. And this is an example where you have the CT at admission, and you see that the patient here on the third part of the duodenum, there must something going on. You do not recognize anymore the normal structure. Also see that there is fluid behind the portal vein. So it's retroperitoneal location, but the image here indicates that the third portion of the duodenum must be involved in the injury. And in fact, the upper GI series shows several days later that you have a hematoma, and all hematomas in the duodenum are treated by conservative treatment. So it's very important to make the difference between perforation and hematoma. There is no gas bubble, there is no intraperitoneal effusion. You have a little bit of extraperitoneal, retroperitoneal effusion. That's not so important here, and conservative management was applied, and you didn't need any oral contrast or pacification. In this other example, it's chosen from the colon, and you see here bleeding. Is it post-traumatic bleeding? The patient got an injury to the flank, and if you would have or pacified this colon before, of course, you would never have seen the hemorrhage inside of the colon wall. And here you have pericolic effusion in this patient. So no more oral contrast is given. So having said that, now the patient is on the table, there's no preparation, you know about the standardization of the positioning. What is now the examination protocol? So probably we are all using now 16 or more row multi-slice CT, a collimation at 0.6, a lateral topogram first through the head and the neck, and then we inject the contrast medium, high concentration at a relatively high rate, 4 milliliters per second, with a very secure IV line. And then we start the scanning of the thorax with a delay of 30 seconds and the scanning of the abdomen and pelvis at the portal phase at 70 seconds. I feel that multiphasic IV contrast medium injection is too complicated when you are in a hurry on an emergency basis. So very simple protocol, only one phase injection, and then you wait for 30 seconds to scan the thorax, and you are waiting for 70 seconds to scan the abdomen and the pelvis. So, and forget about whatever is written in the literature. Forget it. Fancy. Nothing to do with complicated trauma patients. This is just if you have time enough to count metastases in the liver, and even if you count them 23 or 25, it doesn't make any difference. It's very nice, and it has nothing to do with management of trauma patients. Here we save the life. There is an alternative protocol for pelvic trauma which has been described, and it might be interesting in some patients where your attention is immediately attracted to the pelvis, and there is almost a 100% certainty that the patient is bleeding from the pelvis. Here you can start with the pelvis. Okay, you are injecting 100 milliliters of contrast, high concentration, the same velocity of injection, and you start the scanning at 20 seconds, and then at the portal phase, you go back to the thorax and you go back to the abdomen. But it has to be said that most important bleeding, whatever you do, you will recognize it on the abdomen or on the pelvis, and you do not need really to start with the pelvis. But if you would do this is a patient with abdominal pelvic trauma, and you see the very important extravasation here in the perineum, and you see here in another patient, you see the extravasation in the pelvis. We are not using this particular protocol in order to standardize a maximum. And I would say that massive widespread contrast medium, which is close to a large vessel, is almost always of arterial origin. The venous bleeding is delayed somewhat. It comes a little bit later. It is not so massive. The next question is standardization, in the standardization range, delayed scans. Do we need delayed scans? Is there any interest to do a delayed scan? You have to scan at the right time, not too early, not too late. Okay? But then comes the question of the urinary tract, rupture of the urinary tract. In the renal pelvis, in the ureter, in the bladder. In order to see this, you have to have delayed scans. And 5 minutes is, I think, it's the right place to do. 2 minutes is a little bit early, but you can already see that there is extravasation of opaque urine, but it's better to scan at 5 minutes. Too late would obscure a bleeding site. The confirmation of opaque urine is almost always obtained if you are using delayed scans. Is it needed very often? Well, whenever you have a suspicion, and in this paper it was needed in 2% of the patients. Very important remark is concerning the bladder rupture. The best way to see all types of urinary bladder rupture is to make a combination between CT and instrumental cystography. You have to fill the bladder with the catheter. So you have to be sure that there is no urethral rupture, of course. And then you put the catheter in the bladder and you fill the bladder. This gives better results than the IV or pacified bladder during CT. So you have to keep that in mind. The best is the combination of CT and instrumental retrograde cystography. And here you have an interstitial rupture that was not seen on the conventional opacification of the urinary bladder by intravenous injection. Okay, here's a nice example where you see extravasation of urine, which is in a dependent position, of course, in regarding the kidney. It's a very severe trauma, a rupture of the right kidney and rupture of the renal pelvis and extravasation of the urine. So remember, delayed scans at 5 minutes will allow you to show this injury. Then the next question is, should we have pre-contrast scanning and then only injection and contrast scanning? Well, let me put it like this. If you would do the pre-contrast scanning, the whole process is so rapid that you really will not lose time. If you do not do it, you will not miss significant injury, but you may miss some minor injury. And in this example, for instance, you see some small hematomas here in the liver, which correlated better with the elevated liver enzymes. And if you do only the post-contrast examination, you don't see this grade 1 injury, small injury. So theoretically, it could be interesting to have a pre-contrast CT, but usually now we are not doing it anymore. Another example which illustrates that it is fine for the explanation of the disease. This patient had trauma to the liver. And here is an hematoma that is already on the way of liquefying. Then the patient fell into collapse. He collapsed hemodynamically. And the pre-contrast CT that there is rebleeding, new bleeding inside the hematoma. And you would not see it only on the post-contrast scan, but you see that there is old hematoma and there's new hematoma on the pre-contrast scan. You don't see it on the post-contrast scan. Okay. Pre-contrast is also interesting to differentiate calcification from contrast extravasation. This is a patient with a huge hemangioma, trauma to the abdomen, and you see there is a difference on contrast between the calcification, which are not so dense than the extravasation. So pre-contrast, post-contrast allows to make a difference between calcification and between extravasation. So if there would be no extravasation on the pre-contrast, you would say, well, the patient has calcification and there is no other opacification behind. If you do both, you see the contrast medium is much denser than the spontaneous calcium. So, well, another small advantage in very rare patients, of course. Then we are coming to the viewing protocol, how to look at the images. There's no established published protocol, but it's very important that you apply the soft tissue windowing, the bone density windowing, and that you are doing reconstructions. So, particularly for the phrenic injury, sagittal and coronal MPR views are essential. And also for the spine, for the rib, for pelvic, for all bone injuries, MPR is very important. But MPR viewing alone is not recommended. So please look first at the axial images and then you look at the MPR. So this is a nice example of phrenic injury. You see here the liver, which is high standing. So is this just a high position of the liver or is it phrenic rupture? It can be very difficult on the right side. And only on the MPR, you see that there is a rupture of the diaphragm over there. So it's important to look also at the MPR images. So the next mistake is to overdiagnose. Do not diagnose the patient to death. There's absolutely no interest to have a complete diagnosis in a dead patient. So you have to know when to shorten your diagnostic process and send the patient immediately to surgery. And as an extreme, that means just tell the surgeon, does the patient bleed above the diaphragm or below the diaphragm? Finished. And then the patient goes immediately to surgery. So you have to have the courage not to go on diagnosing a patient and just stop the diagnostic process. Time is life. Shorten the CT examination time and overall diagnostic process. Concentrate on the main diagnoses which are life-threatening and also prevent hypothermia. And radiologists very often are contributing to hypothermia because the patient is feeling too cold in our examination rooms. And hypothermia influences metabolic acidosis. And metabolic acidosis has a negative influence on coagulation. So just covering the patient and keep them warm in radiology contributes already a lot to the management of these patients. And then you have to recognize on the images what shock means. This is shock. You see the aorta is retracted and there is no blood going to any of the viscera. You have to recognize shock, of course. The shock can also be selective and you have only one organ that is in vasoconstriction. And it's very typical for the spleen and can also be the case for the pancreas. So in this patient where you have vasoconstriction only of the spleen, do not look for a vascular injury if you don't see it. There is no vascular injury. It's selective vasoconstriction in shock in the spleen. And the same can happen also to the pancreas. So you have to be aware of this. These are selective signs of shock. This is a patient with a very severe shock which developed on the table. This is no rupture of the liver. This is reflux of the contrast medium in a patient in shock in the post-sinusoidal normal spaces in the liver in the dependent position. Extreme images of shock. Mistake number 4 is to miss a significant post-traumatic injury on multi-slice CT at admission. And this concerns everything. And this is a study published a couple of years ago. And you see many diagnoses, even very important diagnoses, can be concerned. So there's always place for mistake. And small bone fractures are the most important, of course. What are the reasons of not seeing those injuries? Well, they can come from the technique, from the machine, insufficient contrast enhancement, you may not see extravasation, wrong timing of acquisition, you are not doing delayed scans, you do not see the rupture of the renal pelvis, too thick slices, you do not see a small pseudoaneurysm, too short body coverage, particularly in the perineum. All the perineum has to be completely covered. And then, concerning the doctor, artifacts, inadequate windowing, rare injury, pre-existing lesion, and fatigue, also fatigue. People working for 10 hours, 12 hours, that's too much, and they miss important diagnosis. So concerning the anatomy, what are the structures where you may miss injury? Tubular structures mainly, or the flat structures, all kind of ducts, the diaphragm, mesenteric injury, small pseudoaneurysm. What is small? Less than 5 millimeters, and also delayed extravasation that would not be seen. And let me give an example of injuries in ductal structures. This is injury to the bile ducts. You see the hematoma in the gallbladder, also in the colodicus. And usually you do not see this, but a few days later, then you see that there is a biloma. And the biloma indicates that there was rupture on the bile duct. The same applies to the pancreas. When you have complete rupture of the pancreas, you may not see rupture of the pancreatic duct, and it needs endoscopic pancreatography in order to see the extravasation of contrast media. Mistake number 5, we are coming to the end, is missing ongoing hemorrhage or a potentially bleeding injury, or to indicate the wrong source of the bleeding. You have to recognize ongoing bleeding. How do you recognize ongoing bleeding? By progressive dilution of contrast in the hemoperitoneum, spread of contrast beyond the capsule of an organ, increase of hematoma on different scans, or a vascular injury, or vasoconstriction and one of the above, or hemodynamic instability and one of the above. And this is a nice example how far you have to go to see extravasation. This patient had increase of size in a psoas hematoma, but we couldn't see any extravasation, and it was necessary to put the catheter in the inferior epigastric artery and make an injection in order to see arterially enhanced CT and the contrast extravasation, and the patient was embolized, of course, on the table. Another example how you can be misled by showing the origin of the bleeding. Here you see the inferior pole of the right kidney and extravasation. You may say, well, the patient is bleeding from the renal artery. You are looking at angiography. Renal artery is normal. Only small flattening of the inferior limit of the kidney. And you see on angiography, there must be an inferior polar artery, and that polar artery is ruptured. But you don't even see the artery, and you have to embolize an artery that you don't see. So you have to look for the artery and to find the origin. The origin was here, and embolization of non-existing, not non-existing, but non-existing on CT artery, and misled by the CT examination before. And finally, the last mistake, I chose only 6. The principal ones: overlook minimal post-traumatic abnormalities that might be highly significant. So what would I say? I would say you have to look very closely to the spleen. The spleen and the pancreas are never your friends. They are always enemies. Pancreatic disease is always complicated. Splenic trauma, you can never predict if a splenic injury will rupture, yes or no. So you have to be prepared, and you have to pick up any any subtle changes in the spleen. And the same for small vascular lesions, small aneurysm. Small, once again, means 5 millimeters. Difficult to see on CT. All people tell you, well, you will see all kinds. No, it's difficult to see a vascular injury of 5 millimeters. And concerning perforation, look for micro gas bubbles. Micro is very small, 1 millimeter, small outside of the GI tract lumen. Well, these are examples, very small pseudoaneurysm, a little bit denser than the pooling contrast, a little bit denser only. This is normal. All this is normal. This is a vascular lesion inside the spleen. You have to look at that. And this is a patient with minimal vascular injury. There's almost nothing around the spleen. And the patient had splenic rupture a couple of hours later. You cannot predict what the spleen will do in the next minute. This is an example of micropneumoperitoneum, small bubbles, small, very small. You have to look for them. Very important, saying there must be a rupture, small rupture at that moment of the GI tract. And you have to be aware if the gas bubble is behind the cruise of the diaphragm, then it has to come from above, pneumomediastinum, but you have seen it already before when you scanned the thorax. Well, I'm at the end, and I would like to thank you for your attention. And if you want to learn a little bit more, please come to the workshop. And I have also 3 books to recommend to you. And I'm particularly grateful for the effort of Professor Valentin Zinitsin, who made the translation of this book also in Russian, and it's available. Please buy it and learn it by heart. Thank you for your attention.